So you've had your surgery, either neoadjuvant or adjuvant therapy, and unfortunately, after a few years and sometimes a few months, the test shows that the cancer has spread to other areas. You have developed metastatic disease. Um, uh, how do we approach melanoma at that stage? And I'm so happy we have Dr. Meredith McCain here, who is a star trialist and has been involved in many, many, many clinical trials for advanced melanoma. And she's going to give us her take on how to approach these patients today. Thank you, Dr. Meredith, Dr. McCain.
Great. Well, thank you so much for the opportunity to be here to speak with all of you today. Appreciate the invitation. So just wanted to touch on just some of the exciting kind of novel therapies coming through, maybe some things to consider as a patient or if you have a loved one with melanoma. And certainly, if nothing else, hopefully after these 20 minutes, you'll feel hopeful that there's a lot of options coming. So my topic is new and emerging treatments in melanoma. So it's really the CheckMate 067, that was the landmark trial for patients with metastatic disease. And this has really been the foundation for treatments, as previously discussed in the now moving into the neoadjuvant setting. In CheckMate 067, we now have 10-year data that demonstrates that nearly 50% of patients with metastatic melanoma are still alive. This was really the landmark and was FDA approved back in 2014. And I always like looking at a timeline because we know that we just really didn't have any breakthroughs. It was really only IL-2 until these checkpoint inhibitors and targeted therapies were developed, initially approved back in 2011. We've made progress. We've had a number of different approvals, with the most recent being TIL therapy. And so we have options that we can offer to patients, right? You can see we have several different immune checkpoint inhibitors. We have TIL, we have targeted therapies for patients with specific BRAF V600 mutations and TVEC. But why do we need more? And this is conversations that all of us in the field have to really push to others that look at that list and may say, well, melanoma, you guys have made such great progress. Why is it that we need to put more funding, more efforts into this space? And why do we need less toxic treatments? And that's because of exactly why probably all of you are here today. It's because of you. It's because of, your brothers, your daughter, your friends, your spouse. We still have patients that we're not curing their melanoma, and we need to do better. And so even though we've made significant progress with Ipi-Nivo, which is the landmark treatment that we have, we know nearly 50% of patients need second-line options because they're progressing. And so today we're just going to go through some of these trials that are ongoing and just some efforts that we hope are really going to change the field. So just briefly touching on immune therapy. So for historically, PD-1 was what I always tell patients, that's kind of the workhorse drug. This is the drug that we were giving in the neoadjuvant setting till we had data for Ipi-Nivo. We were giving in the adjuvant setting for stage 2 and stage 3 melanoma patients, and was the kind of primary mechanism of treatment that we would offer in the metastatic setting till we've had combination therapies that we know are effective. And so for patients that have progressed on just PD-1, Ipi-Nivo gives us a response rate of about 30%, so significant shrinkage of their disease. And that's really set the bar for what we expect and hope for what we consider at least an advance, but we really want it to be higher. And we know for patients that have progressed on either something like pembrolizumab or nivolumab by itself, maybe in combination with Ipi, and we try to use these newer LAG-3 combinations, the response rates just still aren't where we want them to be. So they're about 10 to 13%. So that's where TIL can come in place until we have data demonstrating objective response rate of 30%. We know some patients can be cured in the refractory setting, but we still need to do more. So I think Dr. Hernandez-Aya is going to discuss some of the PRAME molecules, but just wanted to lay the foundation of what are some of the novel targets and new areas that we're looking at. And so PRAME, I think, is certainly exciting. The way I think of it is this is a protein that's it's considered a cancer testis antigen. And so it's a protein that can be normal in certain settings in cells that are growing in the fetus, but really should be turned off. And some of you are probably familiar with PRAME testing on the primary tumor, and a lot of that work was done there at the Sylvester Cancer Center with Dr. Letsky, Dr. Hernandez-Aya, and Dr. Harbour, and really demonstrating the importance of PRAME as a prognostic tool in primary tumors. And we now know in patients in metastatic disease that when this is turned on, it can be very specific to cancer. And so this has been utilized in several different treatments that are ongoing in clinical trials. And I'll let Dr. Hernandez-Aya explain that a little further. We do have a number of other different IO options under investigation. IL-2, there's a number of different trials in this space. This is because we know IL-2 was effective. That was kind of the only effective therapy that we had for patients decades ago. The problem is it was highly toxic. And so these had the only treatment options that you had for patients were IL-2 based therapy that patients would generally have to be admitted to the ICU in case they needed blood pressure support because of high-grade fevers, fluid, causing significant drops in the blood pressure or swelling. And so there's a number of different trials coming back to that now and saying, okay, well, we know it can be effective, but the toxicity profile is too much. So how can we be maybe more selective with what we're activating with IL-2 to be effective? We have other cytokines or stimulatory molecules like IL-12. We have HSV encoded viral particles, other live viruses, anti-CCR8, TGF-beta. So really looking at all the other components of the immune system to say, what else can we activate? Moving into targeted therapy, which is where we'll spend a little bit more of our time today. Most patients are probably most familiar with BRAF mutations. This is standard of care testing that should be done on any melanoma. Certainly, stage 3 can be considered and done, and most definitely in the stage 4 setting, that's absolutely standard of care that patients should know what their BRAF testing is. So we know that about 40 to 50% of patients have a BRAF mutation, but also about 20% of patients have an NRAS mutation. And though this is important because NRAS mutations do lead to signaling through CRAF, kind of alternative pathways, instead of purely a BRAF mechanism. But this RAS, RAF, MEK, ERK pathway is where we see a number of different driver mutations for patients with melanoma. And this leads to that cell proliferation, survival differentiation. The way I explain it to patients is these are stoplights that are permanently turned on in a cancer, that instead of having that red, green, yellow appropriate signaling, they're just green, telling those cancer cells to grow. And so while we do have several FDA-approved treatments, vemurafenib, dabrafenib, and encorafenib, and then our MEK inhibitors, these are primarily for patients with BRAF V600 mutations, and these aren't effective for patients with NRAS or maybe atypical BRAF mutations. And so I take us back to, even for patients with BRAF V600 mutations, I think targeted therapies have gotten maybe I wouldn't say a negative connotation, but they've certainly been pushed to the side in the frontline setting because we've now had several studies, most prominently DREAMseq, demonstrating for patients with metastatic melanoma with a BRAF V600 mutation, we know the best chance of long-term survival is starting with immune therapy. But why is targeted therapy important? Well, if you go back to the initial phase 1 trial of dabrafenib, This is pretty impressive. So this is a waterfall plot, right? This is the percentage of shrinkage of tumor in patients with metastatic melanoma. This was such a game changer at the time, and really shows, I think, that targeted therapy can be very helpful and can still be a very good tool. We are just maybe more selective or more thoughtful about the sequencing and when to use these therapies. But certainly for patients that have maybe progressed on immune therapy, have had toxicities to immune therapy, maybe have autoimmune conditions, targeted therapies are still really a really critical piece of the treatment algorithm. And so while we know that most patients with BRAF V600 mutations benefit from IO followed by targeted therapy, the big question is, well, who else might benefit and what else can we target for patients with melanoma? So I think it's important to know what your mutation status is, and beyond BRAF, really patients should have DNA, potentially even RNA sequencing. This should be covered by insurance. There's a number of different companies, just to list a couple here: Foundation, Tempus, Caris. A lot of academic centers have their own internal testing sequencer. And this can be tested on either tissue or blood. And this is an example of a report that this patient would have had IHC testing that was negative for BRAF, but it's important to know that this patient has an atypical BRAF mutation. And so can this open up other treatment options? These atypical BRAF mutations get classified into class 2 or 3. So class 1 are the classic BRAF mutations. So patients may ask, do I have a BRAF mutation? And that question usually is answered by, do you have a class 1 mutation? Because that's what targeted therapies that are FDA approved work on, or the V600. But class 2 and class 3 mutations, while far less common, are still important for trial options. And you can see here the difference in the mechanisms of action, that the class 2 BRAF mutations are dependent on dimer formation, and then class 3 mutations are dependent on RAS and dimer formation. And so just a little bit different mechanisms of action. When we've tried to use the treatments that are approved for patients with BRAF V600 mutation, for patients with NRAS mutant melanoma, using binimetinib, unfortunately on the NEMO trial, this was a negative trial. When patients received either binimetinib versus chemotherapy, the median PFS was 2.8 months versus 1.5 months, and it didn't improve overall survival. And so this was not FDA approved, and is really was kind of the last phase 3 trial in this setting. But there's been a number of different trials ongoing, or that we have some early data on. So tovorafenib is a selective type 2 pan-RAF inhibitor. And so this was evaluated in patients with, it was a basket trial of patients with other alterations. But in patients with BRAF fusion melanoma, they had a response rate of 50%. And so certainly impressive, and that can be very meaningful for patients. Exorafenib is another selective type 2 pan-RAF inhibitor. This was evaluated both in monotherapy and exorafenib with binimetinib. And this combination demonstrated a 35% partial response in patients with NRAS mutant melanoma. And in patients with class 2 fusions, there were 2 patients with partial responses. So switching gears to CDKN2A, so while we are maybe most familiar with BRAF and NRAS mutations, CDKN2A is incredibly important. So we know that this is inactivated in 20 to 40% of patients with familial melanoma and 2% of patients with sporadic melanoma. So I pulled this from our NCCN guidelines, that certainly any patient that does have a family history of maybe multiple cutaneous melanomas, uveal melanoma, or some other cancers should have germline testing done, and likely in coordination with genetic counseling, just to determine if this might be a mutation that's potentially been inherited through a number of different family members. So what is CDKN2A? This is a heavy slide. Ultimately, this just shows it actually affects two completely different pathways, but both of these are important for cell cycle, for apoptosis and for cell degradation. So what it does is essentially when you have CDKN2A mutations, this can cause these these abnormal cells to proliferate. And so it's important to know, because as we've better understood, exactly which patients may be benefiting from each therapies. One trial that looked at binimetinib in patients with NRAS mutant melanoma and added on ribociclib, which is a CDK4/6 inhibitor, they saw that in patients with the CDKN2A or CDK4 CCND1 alterations, that the objective response rate, the likelihood of tumor shrinkage, increased up to 30%. And then CDKN2A deletions are often found with MTAP loss. And there's several different PRMT5 inhibitors. So this is another oral pill therapy. And early data maybe demonstrated some benefit in these patients. And this is one patient that has been discussed in the literature that was treated with this PRMT5 inhibitor and had a partial response, and certainly significant improvement that you can see on imaging there. So a little bit more about PRMT5. So this is involved in regulation of a number of different cell functions. And so not only is this impactful maybe in cutaneous melanoma, but also in uveal melanoma. We know these patients can be affected by these splicing site mutations such as SF3B1. I know Dr. Letsky is going to discuss more about uveal melanoma later. But for another PRMT5 inhibitor, for 10 patients that were evaluated with that splicing site mutation, 2 of those patients had a partial response and 4 patients had stable disease. So we're going to switch gears a little bit into antibody-drug conjugates. So antibody-drug conjugates, what these are is, the common statement that I may get from patients is, well, wait, chemo doesn't work. And you told me I was never going to get chemo. Well, what this is I like to think of antibody-drug conjugates as a little bit more like paratroopers. It's high doses of chemotherapy going into the tumor. And so we think that this may be effective because that the doses of chemotherapy that we give that goes systemically for patients, chemotherapy isn't a good long-term treatment option for patients. But can we use these proteins that are on the surface of the cells to be able to target the chemotherapy at higher concentrations into the tumor? And so there's a number of different drugs in development for a molecule called HER3. This includes monoclonal antibody, bispecific, meaning just one handle versus 2, or these antibody-drug conjugates. And one example is the HER3-DXd that's been under evaluation for patients with cutaneous or acral melanoma. And why is HER3 in particular an exciting target? Well, you can see here that there's been a lot of evaluation of this undergoing in breast cancer, and melanoma of the skin has similar expression of this target on the cell surface as breast cancer. And so I think just an area of interest there for patients with cutaneous melanoma. So there's a number of other different potential targets that are under evaluation. So Nectin-4, which is cell adhesion molecule, B7H3 and B7H4. These are immune checkpoints. ROR1, so this is a signaling molecule, and then tissue factor. And as we close out, I'll just demonstrate some data that was kind of hot off the press from ASCO this year. This was an antibody-drug conjugate for anti-ROR2. And this was an abstract that was put out by the Sarah Cannon group in Denver, demonstrating that this molecule with a chemotherapy-based payload, that there were several patients with nice shrinkage and ongoing responses, including a patient with a complete response. So on the left is the patient's initial scans and images. And so you can see both responses in the liver and in the lungs. And this can be meaningful even to have a significant shrinkage for a patient, that maybe that patient can then get to surgery or get to radiation, even if we can't get a complete response. So I think certainly more to come in this space. So in conclusion, there's a number of different novel therapies under development. And the reason is because even though we've made a significant amount of progress, we still have unmet patient needs. And until we're curing every patient with melanoma, we have more work to do. There's both new and old targets that are under exploration, and maybe with more novel therapies and delivery mechanisms of how to get it there. Or in the case of IL-2, we're trying to navigate it so maybe it's less toxic, it's easier to give. Some of these trials are now just clinic, patients are just seen in the clinic and not even admitted, let alone in the ICU. We've come so far. And then we have new modalities such as these antibody-drug conjugates in melanoma, and a number of different trials ongoing. And happy to answer more during our Q&A. So thank you for the opportunity to be here today, and for all of your attention on this Saturday morning.